Okay, thank you very much, Alex. What I'm going to try in the next talk is try to see how things are put together. The surgery, the radiotherapy, the chemotherapy, and also not to forget the radiologists and the pathologists and the nurses and the advocates and everybody else. My talk will be on the utilization of multidisciplinary management tumor boards in Arab countries. I have done this with a list of collaborators from several Arab countries: Dr. Asmar, Haj, Bunajjar, Khatib, Ajarim, Jazi, Shamsuddin, Jaara, Abdul Qadir, Attan, and Al Khair, Abu Al Khair. We will start. I like to put those start. I hope I'm not gonna marathon this talk, although we are a little late. So the Arab world, of course, every one of us know, 22 countries in Asia, Middle East, and Africa, more than 300 million people. Most of them, I would say, fall under the category of limited resources. Some countries, have good resources, but when you look at populations, they may be, if you look at the some of the Gulf countries, maybe 500,000 or 1 million or 5 million, but if you look some country like Egypt, 80 million people. So most of the people do fall under the category of limited resources. The tumor board, the subject of my talk, as everybody knows, the best treatment of cancer patients really achieved through multidisciplinary meetings that we call tumor boards. It's a meeting where various experts in cancer management meet together, discuss findings, diagnosis, and treatment of cancer patients. This is the tumor board at, I think you put my earlier version. Where is she? Excuse me? This is not the, let me see. If we can go to the,
yeah, that was the one you gave me. Here.
We put it on the,
This was the one you gave me this morning.
the one that I just gave you?
Mm-hmm. Should be the same one.
No, it's not the one.
Yeah, that's the one you gave me this morning. That is the one you gave me this
That's the
morning.
one I gave you this morning?
Do you have your jump drive with you?
Sorry for this. This is not the one.
Okay. Give me just a minute.
Okay, anyway, I'll...
Here, let me just...
I'll manage. Don't
You
worry.
can run it off the jump
I'll
drive.
manage. Don't worry about it.
You sure?
Yeah, I'll manage. It's okay.
Okay.
We don't want to waste more time,
Okay.
but it's okay.
Well, let's just bring it up here real quick then.
Just keep it.
Okay.
Anyway, okay. Of course, with the PowerPoint, as you know, we always make changes. I have made some changes even this morning, and I gave her the presentation, but it didn't load. What I wanted to look at here is that, to have good treatment for cancer, you need to have the resources, and you need to have the healthcare providers. So what is the situation of healthcare providers in Arab countries? Well, the healthcare depends really on the doctor who is delivering the care. Now, is there any monitoring of results in Arab countries and most countries with limited resources? The answer is that it is very limited. For instance, morbidity, mortality exercises are rarely practiced in countries with limited resources. And also very little monitoring of outcome in those countries. So that's also when it comes to patients, the education and the medical knowledge is really variable. Printed and clear information given to patients, again, is very limited. Now, if there is suboptimal management, it goes easily unnoticed. There is very little in terms of liability, in terms of, paying for suboptimal management, although sometimes there are disproportionate penalties, but very often, even if the cancer is suboptimally managed, the patient and families accept it as this is whatever happens is God's will. So with all this in the background, you understand now that suboptimal care can easily really go undetected in countries with limited resources. And that happens in Arab countries. And when it happens, it is deplored. We say, sorry, that's, God's will. Very often that's what is said. So this setting of suboptimal care makes the need for tumor boards greater in those countries. Most of those countries have physicians trained differently in different places. Some of them are excellent, some of them are medium, some of them are really bad. We have to admit that. Most countries have no standard requirements for licensing, no standard requirements for specializations. People can get easily, degrees, or if they have a degree some 30 years ago, they would still go on with the same knowledge. Most hospitals have no printed guidelines for diagnosis and treatment, and most hospitals do not update credentialing and renewing of privileges for their staff. So the level and optimality of care really depends on the credentials of the individual physician. If you have a good doctor, you get well treated. If you're not in the hands of a very good doctor, you don't get optimal treatment. Hospital equipment and resources also are important, and also the patient's ability to access the available resource is important. So all those really make the tumor boards essential in those places, and trying to make optimal decisions in suboptimal conditions. Now, how multidisciplinary management is delivered, of course, a breast unit is the ultimate goal, but that is difficult in countries with limited resources. Breast tumor boards are first step, our everlasting step, very important. As we say, experts meet and review and discuss all treatment options. The recommendations can be made based on published guidelines and also expert opinion to get the best possible care for every particular patient. Why do physicians attend tumor boards? To get an opinion, to manage their patients, participate in group decisions, and also for continuing medical education.